On this episode, we're wasting some time chit-chatting about nonsense, and we're talking Acne Vulgaris treatments. Check it out. Hello everyone, and welcome back once again to the Core Consult RX podcast. My name is Mike Corvino. With me as always, my co-host Cole Swanson. How is everyone doing today? Cole, how's it going?
Doing great. Acne round 2 now, I guess. And if you
Yes.
count today, it might be round 7, I think.
Yeah, so here's a cool story. We actually have already recorded this podcast, episode 8, but now it's lost to time. Because, contrary to popular belief, I'm actually not a audio engineer, and I completely wrecked the audio from last time, and it was not salvageable. So
Maybe sometime in the future when we have a Core Consult RX archive of hundreds and hundreds of episodes, we'll release this one as like a little Easter egg.
yeah, that way we can lose all of our followers immediately when they hear how bad the audio is.
You'll be loyal by that point,
Yeah.
so maybe we won't lose you.
You're just going to be like, wow, they went in a completely different direction. They overlapped their sounds. They didn't make sense. It was terrible. But the thing is I bought this big fancy mixer, and it's got a ton of knobs, where my last little interface had 2 knobs, and that was very easy to
Just plug and go.
Google, look up how to use it. This thing is just it sounds better, but it's just the worst to how to.
So if you're an audio expert and you like working for free,
Especially if you like working for free.
let us know.
Because we need one. Because, yeah, we've wasted a ton of time. So, apologies to our good buddy Morgan, who was kind enough to record the episode with us. And now she is off in Colorado, I think so. Colorado on rotation. So, we'll have to get her back on.
Yeah, we'll get her back.
When she gets back. But it was a great episode. You guys are going to have to take my word for it.
On
It
the
was
bright side, this will
solid.
be even better.
Because we've already done it once.
Money back guaranteed.
Of course, it was over a week ago, so I don't remember what we're going to say.
Right.
So, once again, we're going to wing it.
Great start. Excellent.
Yes. So, which rotation are you on right now?
I'm on a psych rotation.
How's it going?
It's very interesting. The patients are fascinating. I haven't really had a specialty rotation like this yet, so definitely getting a lot of exposure to the psych meds. Maybe we'll do a like an antipsychotic or bipolar podcast coming soon. Who knows?
Yeah, that'd be good.
Just
We should
because
definitely do that.
it's in the brain. So very interesting patients, very interesting medications too. So yeah, we'll see.
For sure, we
Stay
should definitely
tuned.
do that. You'll probably notice that, especially going forward, I think, based on the rotations that Cole has or the particular part of the lecture that I'm at with the PA school, they will probably mirror that.
Coincide.
And that's because we don't want to write 2 different sets of material.
Right.
And so we're just going to write the one.
We work smart and hard. We
And
do both.
hard, yes.
Yeah. Speaking of which, how was the vacation?
It's good, man. It was really good. We have not, like I was telling you earlier, Jen and I have not actually gone on a true vacation, other than maybe we did one weekend trip to Orlando a couple years ago, but we have not been on a vacation and since our honeymoon, which is 5 years ago. So
That's ridiculous.
yeah.
Yeah.
So
you
part
need
of
more.
that.
You need a little more vacations. And he was working the whole vacation, by the way. Don't let him make you think it was a true vacation.
No, I wasn't working all that hard though. It was mostly Instagram and core consult stuff. It wasn't really anything actually work related.
Right. This is all for fun.
Yeah. So we did go live on Instagram, which was pretty fun. I hadn't really done much of that. And I thought so my buddy Rich, who was with me, and we both went live from our phones, sitting next to each other. And I thought we were literally going to get 0 people, because I was like, I don't know why we think we're so fancy now. We're going to go live and people are actually going to listen to us.
Right.
And because we were like, oh, ask us questions if you have questions about pharmacy school or branding or whatever. And we put this out there, and I'm like, this is going to be so embarrassing. We're going to have 0 people even click on this thing. But we actually had a lot of questions, and it was actually really fun. So
Yeah.
maybe you have to start
Is
doing
that
it again.
archived? Can you still listen to that, or
No.
does it just go away?
Well, you can, because I have it filmed, but I haven't put it together yet. I'm
Gotcha.
slacking on the pharmacy vlogs situation.
We'll get that done. You
I know.
got plenty of content. We just got to.
I know, I got
Put it
a whole hard drive full of just stuff I've filmed, random nonsense. But A lot of it's pretty good. I just have to actually piece it together now, and I'm gonna get a lot more serious with the vlogging. Some people think that's not really gonna catch on, but we'll see. I feel like some of those videos, especially on Facebook for whatever reason, have caught on, or like have the most views, and then some of the most views on YouTube as well from all my stuff.
Right.
But we'll see. At least if nothing else, it'll keep some interesting people coming around.
Well, cool. Thanks for listening to our 6-minute housekeeping anecdotes, guys.
Yes.
Keeping it interesting.
Minutes of non-medical just talking.
You got a break.
Yes.
You got a
thank
break.
God. All right, so
anyways,
I think before we kind of get started, because we don't have a guest today, obviously. Before we get started, we will kind of go into a new section, if you will, a new event that'll happen. I don't want to say every podcast, because who knows if we're going to plan it out that far.
We don't plan that far.
But we'll say it'll be a new segment of some of the podcasts, and it's called That Drug-Drug Interaction. So, the reason I bring this up is because Morgan, who was supposed to be on our podcast with the original episode 8, the lost episode, she had called me that day, actually, from her rotation. I guess our preceptor was out sick or something, and she was kind of by herself a little bit. There was other pharmacists, but not that were like directly supervising her. And she had a question that her and some of the other pharmacists I guess she was working with were confused about, because a patient was on venlafaxine and then was also on Azilect for Parkinson's. Well, when they ran a interaction check, because they do that on all the medications, it came back as anyone who is on a MOAB inhibitor MOAI inhibitor, because it just says that by itself, that it's completely contraindicated with any kind of SSRIs or SNRIs. And so she called me asking about it because the doctor was trying to change it, but everything they were trying to put in the checker to change it to was still coming back with the same interaction, because it's still affecting serotonin, so they were worried about causing serotonin syndrome in this patient.
Right.
So the thing about Lexicomp, and I'm a huge fan of Lexicomp. By no means I'm saying don't use it. I love Lexicomp, use it every day. But the interaction checker on there is 99% of the time very accurate, but it doesn't always have the ability to differentiate between certain like subsets, I guess, of a drug.
Sometimes it's kind of broad.
Right.
Yeah.
And so for this example, the MAOI that it's referring to is the A version, which is what's responsible for breaking down serotonin and norepinephrine. And so if you're giving that and you're inhibiting that process, that breakdown, and then you also add on something that will increase serotonin levels as well, then we definitely run the risk of serotonin syndrome. However, Azilect is specific for the MAOI-B, which is where you are breaking down dopamine. And so that's why they're using it specifically in Parkinson's. And so it's got a 14-fold more affinity for the B receptor versus the A, or subtype, not receptor. And so when you block that enzyme, then you're blocking the dopamine, you're helping with Parkinson's symptoms. But there's many, many, many case reports of patients who are on that along with venlafaxine or duloxetine, even regular SSRIs, and having no problems whatsoever, not having any issues with serotonin syndrome. And so the thought is to monitor, and in most cases, though, that the benefit will outweigh the risk that may not even be there based on kind of the medicinal chemistry of it.
Right, and that was the MAOB component, right?
Yes.
That Azilect acts on. And if I remember correctly, I think the MAOA component is what's responsible for breaking down norepinephrine and serotonin.
Yeah.
And I think the B is also the tyramine component, which is why people who eat tyramine-containing foods who are on MAOIs, which is, I think, a non-specific inhibitor, it inhibits both, could have a hypertensive crisis. And that's, little trivia there for you to be aware of.
Yes. And, the reason I even bring that story up is not to call anybody out or say anything about any interactions or anything like that, but it's mostly just because sometimes that you really do need to use clinical judgment, primary literature to come up with a answer to the problem, because the Lexicomp, it's not going to be able to differentiate those two. They probably wouldn't anyway for liability reasons.
Right.
But we do have primary literature that shows us that we can do it. So it's definitely important to use your clinical judgment and look for those kind of special case scenarios, and not just take everything that we read in an electronic reference um, to heart. Now, if it's this podcast, 100%
Yeah, right.
take it to heart because it's fact.
Perfect.
Perfect fact. Maybe even law.
We don't make issues.
I'm just kidding. Don't do any of that.
Grain of salt, everybody.
Yes.
Grain of salt.
Don't sue us. All right.
Cool.
So, in the other thing too, I'll add this is before we transition out of that that segment, but that patient could have had a medication that was really helping her because she was stable on the venlafaxine. She wasn't having issues with her depression. They could have had that stopped and switched off and had a medication stop that she was really helping her if they hadn't been aware of that interaction and had actually stopped it and started her on something random. So the interactions, even when we're trying to actually help people, can cause harm. So you got to make sure you're looking at them close. Mm-hmm. And if for all of you who are like first year pharmacy students or studying pharmacology somewhere in a PhD program, and you're saying medicinal chemistry is nonsense and when am I ever going to use this, you're going to use it.
There you go.
So
use your brains.
Keep going.
Cool. Well, you want to get into this?
Yes. So today we are going to talk about Acne Vulgaris.
Yes,
because I feel like it is a topic that we don't always touch on a lot when we're on rotations and things like that. Not too many pharmacists are doing like dermatology rotations.
Right.
And
it's usually kind of an afterthought because a lot of people have bigger issues going on, but it is a big issue for a lot of people and it's very ubiquitous. So it does apply. Especially,
and here's the thing, like people like me who make my living off Instagram. You need to have
right. You got to look good.
Yeah.
But this is a podcast, so you can't see it. Oh well.
Yeah, you can. There's a video version.
Yeah, but if you're listening,
Cool. Forgot about the video version.
Then you can't see. All of our blemishes and whatnot.
Yeah, which is good. But if you want to see blemishes, watch the 4K video.
Right. Exactly.
All right. So patient case. We have JB, who is an 18-year-old white female with a history of mild to moderate comedonal and papular-pustular facial acne. She is currently using Tazorac 0.05% cream. She admits to limited adherence due to skin irritation from the medication, which is pretty common with Tazorac. She also is on a Lavora, which is levonorgestrel and ethinyl estradiol for birth control. You note that her skin does seem to be somewhat oily, which she says is fairly normal and something she has to combat. So where should we go as far as treatment? Should we just keep her on this medication? I want to walk through some of the different options and actually look at the evidence because there's actually evidence for acne.
Yeah, they actually do studies. And, first thing you want to look at is, okay, so what type of acne is it? Acne vulgaris is the most common type. Obviously, we see that she has comedonal and papulopustular. Mm-hmm. So kind of both areas that you want to treat there. And the comedo or the comedone, interestingly, comes from a word that means to eat up, which is a name that they once gave to worms that devoured your body a long time ago. And they think that that's because when you squeeze them, worm-like things come out. So that's kind of gross, as if acne wasn't gross enough. But it's characterized by those two, comedone being the blackheads and papulopustular being the kind of inflamed type of acne.
Yes. I like how you said that worms back when they used to eat us.
Yeah, worms don't eat us anymore.
No, they stopped. They went vegan.
They're vegetarian.
They went completely vegan. They don't touch humans anymore. So that's nice of them.
Yeah.
So the big thing when you're treating acne and you're kind of going through like the algorithm and seeing what you're going to use, obviously is what type of acne. So is there more like just blackhead issues? Is there, the comedonal? Is there actually like inflammation and pustules? Or is there even like cysts? Like you'll see hard, firm little nodules underneath the skin. And a lot of times they'll even follow like the cheekbones and they can even be painful and disfiguring, and there's some cases where acne lesions will get big enough, or if the patient's scratching them, then they can actually leave scars that are permanent. So we definitely do want to treat them, and we kind of look at the severity of where everything falls in and kind of judge our treatment options.
Mm-hmm. And it, of course, it occurs as 85% of people know as an adolescent, that's where
Mm-hmm.
it's most rampant. And for the other 15%, I don't really like you very much. But it can occur post-adolescence and actually relatively commonly. But in your 20s, there's 43 to 51% or so amount of people experience acne, and it kind of goes down from there until age 50 and older. Still 7 to 15% of older adults experience acne. So it's not just in teens and adolescents; it goes throughout your whole life. But the psychosocial, mental, stressful aspect is probably more prominent in the adolescents, I would think.
Yeah, absolutely. And it's something that, like, I know for me, like, I had horrible acne when I was a kid. I don't know if you had dealt with
No,
that at all,
I
but
was one that dealt with it for sure.
yeah, that was terrible. Anyways, so kind of walking through real briefly the pathophysiology before we get into the treatment
Mm-hmm.
options. A lot of times, acne will start with what they call follicular hyperkeratinization, and basically, like a hair follicle, like pore, will become clogged. These keratinocytes are uh, basically replicating and plugging this hole so that the sebum and things that are normally in there cannot escape. They get trapped inside there. There's also bacteria on the skin called Propionibacterium acnes, which I believe, I don't know if it's been officially changed. Do you know?
No,
But
I don't think it's been officially changed, but some people call it what, C. acnes?
yeah, Cutibacterium
Yeah.
acnes, which is cool. It's a cutie bacterium.
Right. It makes you cute.
Yeah, either that or they're talking about cutaneous.
No, I
That's,
think
that
it's
can't.
the cute thing.
Yeah, that can't be it.
Yeah.
So you block that pore, the bacteria, which actually thrive on sebum, are able to use up this extra sebum production because your body just keeps making it. It's not able to escape the pore, and the bacteria replicate and grow and then cause issues because your body will send cytokines and other inflammatory mediators to that area to combat that bacteria, and then you get the redness and the inflammation and things like that when the acne starts getting worse. Now, if the actual like pore, like the lining of that pore actually bursts and all that cellular component, it kind of spills out into the surrounding area, a lot of times it can cause major inflammation and even a hardness, which is where the cystic acne comes from. And there's various things that can cause like this increase in sebum production. There's some studies have showed like a rise in DHEAs. S levels can increase sebum production, but really anything that affects like androgenic hormones. And so androgenic hormones basically will stimulate the sebum production, and so we'll see this in like athletes who are abusing, say, anabolic steroids, because anabolic will build up muscle and all that, but it'll also have androgenic properties where you get excessive hair growth. And then you'll see a lot of patients that have or athletes rather, that have a lot of body acne because their body has such a huge overproduction of sebum, they're just really prone to getting it.
Right.
You can also see it with certain birth controls that are more androgenic than others. Hint, hint. And so there's several things that can cause it, but that sebum production is what draws in the bacteria and allows them to start replicating.
Yeah, and that's what a lot of the over-the-counter therapies target, is that sebum. But the soaps, detergents, astringents, they'll remove the sebum, but they're not going to actually decrease or alter the sebum production. But there are other external factors that go into what might cause acne. Some are kind of theories, some are a little more proven. Diet doesn't play actually as big as a role as I thought it did. There are some studies that show that there's a correlation to milk consumption in acne, which a lot of people might say is due to hormones that they give the cows and whatnot. That the studies didn't really look at that, but they actually found that skim milk or low-fat milk was higher risk than 2% or whole milk.
Knew it.
Right, exactly, which would make sense for the whole, even though I don't really get on board with the whole hormone thing, would make sense because the skim and low-fat milk is actually more processed than the whole milk or the 2% milk. So I don't know. Don't ask me about the whole hormone thing, but family history plays a big role. Stress plays a big role. Insulin resistance can make acne worse. And then there's some studies that show that increased glucose intake can make acne worse. They really weren't sure if that was related to maybe just an increased BMI, potentially increased insulin resistance instead of directly related to the glucose. But that's something to consider. So sodas, Monster might make it worse.
There's no way Monster makes it worse. I don't believe that. It's not evidence-based.
Denial.
So when we are giving a patient a topical medication, whether it's a retinoid or one of the topical antibiotics, whatever it is, we want to consider like the vehicle that the medication's actually put in. So we have all these different creams, ointments, gels, et cetera, et cetera. We want to consider that vehicle and how it would affect the patient. So in this case, a lot of times patients that have really dry skin or they just feel like they're constantly trying to use moisturizers, things like that, they'll benefit from a cream version of whatever drug you're trying to use.
Right.
So she's on a retinoid, you're giving a cream, but she has oily skin naturally, so it's kind of one of those things that you probably don't want to use a cream. You don't want to moisturize the face more if it's already oily. So in her case, a gel would actually be a little bit better. So a gel a lot of times can cause evaporation of the oil or the moisture from the skin, and your face can be a little bit drier looking. And so if oily skin is something you have to normally deal with, a gel would probably be a better option. So as far as the retinoids go, we have three. We have tretinoin, gave it away. We have adapalene, which is the brand name Differin, and then the one that she's on currently is the Tazorac. Tazorac has been kind of seen as the strongest of the three retinoids, but it has also been the one that has the most topical irritation, and patients will complain about their skin hurting and things like that. So in this particular patient, I think that I would want to change her to a gel version of what she's using. But there's a study that was published in the Journal of Drugs and Dermatology in 2005 where they compared Tazorac to adapalene, and there was actually the Tazorac was still a little bit better, but the adapalene had less side effects. But the adapalene that they used was the 0.1% version, and then kind of naturally you would expect Tazorac to be a little bit stronger because that would match with the meta-analyses and things like that. But in 2008, in the same journal, there was another study published that looked at adapalene 0.3%, and they looked at the gel in particular and found that it was non-inferior to the Tazorac 0.1, which is a higher strength than she's already on. But the tolerance and all that remained better and with the adapalene, and patients didn't have as many side effects. So I think in this particular case, I think it would be a good idea to possibly switch her over to the adapalene 0.3%, and change it to a gel instead of a cream.
Sure. And as far as what you're thinking when a patient comes in and you want to prescribe them something for acne, of course the first lines are going to be those topical retinoids that you mentioned. Also, benzoyl peroxide is something else they could try if they haven't tried anything else. It's available over the counter. There's 2.5, 3.5, 5%, and even 10% over the counter. So you would try one of those first before moving on to some of the other things we'll talk about that we may not necessarily do for this patient. But
yeah,
we'll talk
especially
about
since she's already on therapy. She's been dealing with acne for a while. So the other thing to consider is, so retinoids are the go-to for comedonal acne, on those blackheads. Now, she also has pustules, and so we need to worry about the inflammation from the bacteria causing irritation, that cytokine release, and in that case, we also would want to consider antibiotic therapy because the retinoids are, you can still use them for that, but they're not as effective in treating the actual inflammation aspect of the acne as the topical antibiotics and even the systemic antibiotics. And so in her, I would actually consider, since she has like kind of what I guess they would refer to as like mixed acne, where she's got kind of both scenarios going on, I would keep her on the adapalene 0.3% that we just started, and then I would also add on a benzoyl peroxide gel as well, and that way she's covered from kind of both angles. Benzoyl peroxide is over the counter, and that comes anywhere from like 2.5 all the way up to 10%. I haven't seen any strengths higher than 10. And there's stuff in the middle. There's 5. And I think there's like random things like 6 and like 6.5, and who knows. But 2.5 to 10, I think is the usual range. There was a study way back in 1986, where it was the International Journal of Dermatology, rather, and they compared all 3 strengths that were available at the time, so 2.5, 5, and 10, of benzoyl peroxide to inflammatory acne vulgaris, and they didn't see a statistically significant difference between those 3 strengths. So I think if the way to start off would be, especially if it's on the face or anything like that, would be 2.5%, maybe to 5%. But when you start getting into the higher range, like 10, usually you're going to start having a lot of side effects in localized irritation.
Right.
Things like that.
So increased side effects, maybe not increased efficacy.
Right.
And if you wanted, there are combinations of a lot of these topicals, specifically the retinoids and benzoyl peroxide, also the retinoids and the topical antibiotics. So if you wanted to do adapalene 0.3% and benzoyl peroxide 2.5% gel, you said?
Yes.
So that'd be Epiduo Forte gel would be the brand name for that. So you just give them one and they're taken care of. Or you could do it separate. It's whatever, probably a price thing at that point. But
yeah, and the other thing to consider too would be there's topical antibiotics that you can give other than just the benzoyl peroxide. And so because the patient has a lot of inflammation, you may not want to add on 2 separate medications, but it may actually call for that if the inflammation was bad enough. And so there's a study that they looked at the combination of clindamycin with benzoyl peroxide, and it was seen to be more effective when it was the clindamycin was more effective when it was combined with benzoyl peroxide or with a retinoid. And in theory, you could use all 3, as long as you're monitoring for side effects and any kind of irritation or anything like that. And then the clindamycin would probably enhance the effect of the benzoyl peroxide, and clindamycin is sometimes used even for like spot treatment.
right.
And so where retinoids are only going to be used to like cover the entire area, clindamycin can be used as spot treatment, and they make a very nice combination product called Benziclin, which is the combination of benzoyl peroxide and clindamycin.
So that'd be another option for a combination if you want to do it that way. But yeah, clindamycin is going to be probably the most common topical antibiotic. There is also erythromycin. If I had to choose, I'd probably go with Clinda. Apparently there's some resistance to P. acnes with erythromycin, so clindamycin is probably going to be the more common one. People will also use topical salicylic acid. It's pretty common in the over-the-counter products, but the evidence for that is really limited. It kind of just dries out your skin, so I'd probably stick with benzoyl peroxide and then the prescription ones if somebody comes in asking for those. And before you move on to something else, you can really do a lot of combinations of all 3 of these topicals we talked about, the antibiotics, the retinoids, the benzoyl peroxides, for an extended period. Really give it time to see if it works before you move on to what we're about to talk about, which would be the oral antibiotics or even the tretinoin. So
yeah. Also, too, just to throw this in there because I forgot to mention it, but the retinoids, especially tretinoin in particular, is very susceptible to UV light, and so they're typically told to apply at nighttime. Adapalene is the most resistant as far as the UV of all the retinoids, so there are people that will put on adapalene during the day. But if this patient was going to be started on Benziclin and continue with the adapalene, I would use the clindamycin and benzoyl peroxide combination in the morning, and then at night I would use the adapalene. Also, too, before we could jump into systemic antibiotics, there are 2 others, Dapsone, Axone, I believe is the brand name.
yeah.
That's approved for both inflammatory and non-inflammatory lesions. Comes as a 5% that can be used twice a day, and then 7.5% now that's used once daily. Dapsone is a sulfone. It's not a sulfonamide, and so it's not contraindicated in patients that have a sulfa allergy, especially when that sulfa allergy is referring to Bactrim. So if it's a sulfonamide, then the sulfone will not affect it will not trigger that same allergic reaction, so they can still use it. Do know, though, that if you use it along with benzoyl peroxide, it can cause a temporary yellowing or orange discoloration of the skin. And the other topical that we didn't mention was azelaic acid. That's also approved for like antimicrobial, comedonal acid. Or, God,
Comedolatic.
there you go. That's the word I'm looking for. Can't talk anymore. 20 minute after the 20-minute mark, I'm done.
Right.
And then it has some mild anti-inflammatory properties. And then azelaic acid is also used in, I think it is a 15% formulation in rosacea as well. But those are all the extensive topical treatments, at least that I'm familiar with.
Yeah, I did come across one more, the sodium sulfacetamide.
Oh, yes, sulfacetamide
is
and
one
sulfur.
other option, right. The
yes,
sulfur.
The cleanser wash thing.
Cleanser, right. So some people use that in rosacea also. Can also be used in acne. And so that would be, I think, all the options for topicals.
Yeah, and if somebody is looking for something to wash their face with, there are actually good options that you should consider. In fact, there was it was a tiny study, so this is probably not even good to quote this, but I'm going to do it anyway. It was a 4-week-long study, and patients were given a synthetic detergent bar, which was actually a Dove-sensitive skin. That was the soap they were testing, versus what they just refer to as soap. So I don't know what that was, what brand that was, but it was just soap. It was the off-brand.
Right.
And the patients that had used the Dove Sensitive did have better control, and then less dryness, less irritation than those who use the off-brand soap. So it's a really small study. So if you are going to use a moisturizer or cleanser, I would definitely use one that is made specifically for issues with like dry skin or irritated skin or something like that. Yeah. So like Cetaphil. If you need a moisturizer, there's Aquaphor. There's Aveeno makes one. There's a couple different ones. Actually, I put a post up, depending on when you hear this podcast.
Plug.
Yeah, plugging it. There's a post on Instagram and Facebook and maybe Twitter that has a list of all the different moisturizers and cleansers and things that are available that can help with not just things like acne, but also like atopic dermatitis, psoriasis, things like that.
Yeah, and if Aveeno or Dove is looking for some extra, advertising, just let us know.
A couple basically models
right.
to model their soap applying skills.
Close both your eyes and we look great. Anyways, those are all options for what would be considered mild acne. If it's resistant or, some people have very severe cases of acne, that's when you would get into some options that we would consider, further down the line, which one of which being oral antibiotics, which we talked about. Tetracyclines are generally used. Doxycycline is really the most common. You could also use tetracycline or minocycline, but really if you were going to do it, doxycycline is what is preferred. As far as length of treatment, you can look at this from an antimicrobial stewardship point of view and really question whether or not you want to do that. It's very patient specific. But if you're going to, the recommendation is to really try to keep it to 2 to 3 months max. It's not really a long-term solution. And the idea is obviously to decrease the amount of P. acnes on the skin available to be turned into a comedone or a pustule.
Right. And the other thing, so as far as minocycline, there is a brand name, Solodine, that is starting to be used a lot more, and it's like an extended release version of minocycline. That one's approved specifically for acne, and there's all kinds of various strengths of it that it comes in. I want to say that it maybe has a generic coming out soon, or maybe already has. I don't know. Don't quote me on that part. But Solodine, and it's minocycline extended release, and it's just used once a day. So that one I'm starting to see more. I think Valiant's been pushing that. If I recall, that's their one of their drugs. So they've been pushing that one, but it's super expensive. So make sure you get a.
And Doxy's not particularly cheap anymore either.
Yeah, that's true. And so, like, if you are worried about resistance now, doxycycline does have a version that's considered non-antimicrobial dosing. So it comes as a 20 milligram capsule, and then also they have a 40 milligram capsule as well. The 40 milligrams once a day, and it's a combination of like immediate release and extended release doxy. I think it's like 3-to-1 extended. So 30 milligrams of extended and 1 milligram of immediate release, I believe. It might be the other way around. But the other version, the 20 milligrams, you can use twice a day, and it's low enough dose where you're not getting antimicrobial properties out of it, but you are reducing the inflammation that's seen in acne vulgaris specifically.
Right.
So you wouldn't treat a staph infection with it, obviously, but it can reduce, supposedly. I don't know that the trials and the evidence is actually played out to prove that, but in theory, it would potentially reduce the risk of having resistance or causing resistance.
Right, and like you said, it's considered sub-antimicrobial. If you wanted the antimicrobial dosing, generally reserve this for patients who are over 8 years old because of the concern for tooth discoloration, which I think was more considerable with tetracycline, not so much doxy, but either way, just to be safe. And over 100 pounds, you could do 50 to 100 milligrams once or twice a day, and that's what people would use if you wanted the antimicrobial benefit from it.
So to mention the doxy thing, this always sticks in my mind because so for those of you who are not in the Charleston area, one of my buddies and somebody I consider a mentor still is Dr. Scott Bragg from family medicine around here. I was on his rotation and I was pretty nervous. He's a super smart dude, and he asked me a question about Lyme disease in a child. And I was so pumped because I thought I knew the answer. And I was like, can't use doxycycline. You got to use, I forget what I said, cephalosporin or something, because can't use doxy when they're younger than 8. And then he whipped out like 3 articles, 3 review studies that showed me where they've used it in younger children because it was more associated with tetracycline. And then I was like, crap, back to the drawing board. But no, it's good. That always sticks with me for some reason. But so don't put doxy out just because of the age thing. There is some evidence to the contrary. And then hopefully we'll get Dr. Scott Bragg on the podcast here pretty soon.
Right.
So I know he listens every once in a while.
But don't blame us if there's any teeth discoloration.
Yeah. Yeah.
You're your own clinician.
Yeah.
But if you do want a little bit of trivia, antibiotic trivia, pretty much if you have any tick-borne illness, you can use doxy and it's effective. So Lyme disease, Rocky Mountain spotted fever, all sorts of stuff. So if your preceptor or somebody ever asks you that, you can default to doxy, and then if you're wrong, I mean, you've got like a 90% chance of getting that right. So
boom.
Yeah, there you go.
There you go. You're welcome. So the last thing that we definitely need to discuss is isotretinoin, which is a oral retinoid that is saved for really, really severe cases of acne.
Mm-hmm.
And the reason for it being kind of saved to the last is, one, there's a ton of side effects with it. So the patient can have really, really sensitive skin, especially when they first start it. You get horribly chapped lips. If you get like a cut on your skin, on the face or anything like that, it'll scab over and turn. It almost looks like impetigo or something. Because I've actually experienced this myself. I was on Accutane for a few months. Worked great for the acne, but that first few months was rough. And the other thing is it can cause really bad birth defects in children.
Very teratogenic.
And so when the product was on the market, they had to associate a REMS program with it, and it's called iPledge. And so the prescriber, I think typically it's only dermatologists that will prescribe this. They have to be registered with iPledge, have the patient registered with iPledge, and then every time they go to get a new prescription, they have to, if it's a female, have to get a pregnancy test, and they have to make a commitment to at least 2, at least it was when I looked at it last, but at least 2 forms of birth control, whether that's like an oral contraceptive medication, abstinence, it can be condoms or whatever it is. But they have to commit and sign that they're going to use some sort of birth control so that they can avoid pregnancy.
Right.
And then they're given their own iPledge number. And then when they get the prescription from the pharmacy, or the pharmacist receives the prescription, they have to take that iPledge number, go into the iPledge system themselves, who they're also registered with, and then verify that the patient has done all those criteria and that the dermatologist has done their portion, and then they're allowed to dispense it. And it has to be picked up within 7 days?
Yeah, 7, I think.
7 days, or they have to go back and get another prescription.
Right, and I think another pregnancy test potentially.
Probably.
So yeah, it's
a process.
Pretty intense.
So
for sure.
you would definitely want to save that for very severe cases, or if you're worried about like really severe scarring,
Right.
if the lesions are bad enough. So
Right.
you definitely would want to save that though, kind of a last line. You don't jump to that one.
Right. And just so you know, REMS is a program that the FDA puts forward for specific medications. It can be to varying degrees. Sometimes you just have to give out a med guide for a medication. Obviously, this one's pretty intense. It stands for Risk Evaluation and Mitigation Strategies. But yeah, so this one is iPledge.
Yes.
And there's also, we should mention, just lastly, you could use spironolactone is another option that some people try. It's an aldosterone antagonist, so obviously would decrease the androgenic content of your body, I guess. Also a potassium-sparing diuretic, so you'd have to be aware of that. But some people do try that kind of as a last line. They'll use 50 to 100 milligrams. They'll keep it to about 6 to 12 months for acne. But that's another thing you can try for resistant patients.
And they usually use that only in females, right?
Yes, only use that in females.
Yeah.
So obviously the anti-androgenic effect in males, especially of adolescents, could cause some issues. There's a risk for gynecomastia, those sorts of things. So yeah, females.
The last thing to mention too is she is on her birth control called Levora, levonorgestrel. That is actually one of the most androgenic progesterones that you can put into an oral contraceptive. So that's not helping the situation either. So if you were to consider switching that to maybe help the process along, that may be a good option. Drospirenone is a non-androgenic progesterone. So like Yasmin, some of those brand names are a very good option because the drospirenone can help reduce some of that sebum production because you're not getting that same androgenic activity.
Yeah, and I guess in general, more progestinic content is better. Less estrogenic content is better as far as androgenic content goes, or risk of acne. Is that what it is?
I think it's if the progesterone component has high androgenic activity,
Okay.
switch to a non-androgenic
Gotcha.
progesterone.
Gotcha.
If you're dealing with sebum production,
Right. Okay.
or lower the dose at least of the progesterone component.
Makes sense.
So I think, and either that, there's some dermatologists right now listening, just screaming.
Let us know.
Just screaming at me.
Yeah.
You idiot.
Correct us. That's fine.
All right. Anything else for this patient?
That's all the big stuff that I could think of for sure. They don't have any other comorbidities or anything, do they?
Mm-mm.
Just acne.
Nope. Just acne,
Yeah.
which is good because you're only 18.
Yeah.
Yeah, he's a kid.
Got a little while to go.
Yeah, got a while before you start getting all those comorbidities.
Right.
Good deal. That was good. I'm glad we did that one.
Yeah.
Sorry it's been so long since we posted a podcast.
It hasn't been that long since we recorded.
Yeah.
Just since we posted.
Just since we posted the lost episode, took up some time, and then I went on vacation. Didn't get any work done. So
he needs a break.
that was a
Mike works
mistake.
hard.
I don't know. I fake it. All right. Let us know if you have any questions, concerns, comments. You can reach us on basically all social media platforms. Check out the podcast on various podcasting networks and also the video version on Facebook and YouTube. You can email me directly if you want at mcorvino@coreconsultrx.com or send us a direct message on any of the social media platforms. I'll get back to you as soon as I can. And also check out the Alexa flash briefing, which is currently down, and I'm trying to figure out how to fix it.
She heard Alexa and she responds.
Alexa, no.
Amazon's got the voice response going on. Stop.
So, yeah.
Alexa, down.
Alexa, stop talking. So check out the Core Consult RX flash briefing once that's up and running again. So hopefully that will be up by the next couple days or so. Thank you all for listening, and please reach out to us if you have any questions. If you do enjoy the podcast, please subscribe. It would mean a lot to us. If you watch the videos, subscribe on YouTube. And then if you have any comments to leave, we would definitely appreciate those as well, or a rating. Also helps us out. And if you have any feedback, we are all ears and definitely want to improve. So thanks for your time, and we will see you next episode.